Thank you so much, Selender, and thank you much, Binay, for the great invitation. This is a great meeting that you do, and you all the time. I hear great things about it, and this is my first time joining, so I appreciate the opportunity and the effort to improve the educational mission in our area. Can you see my slides?
Yes.
Yes, we can. Yeah.
Perfect, perfect. So thanks again for the invitation. You see my disclosures now, right?
Yes.
Perfect. Okay, so that means that it's moving. So I'll start by just giving the 1,000 feet view of bladder cancer treatment settings, which I think gives you a very broad idea of what we're going to cover today. We're going to start by the non-muscle invasive disease, so some brief data there in the recent pembrolizumab approval that we actually played a significant role in that. Then we'll move into muscle invasive disease, and we'll end up with metastatic urothelial cancer, including the Javelin Bladder 100 trial that Selender nicely included in his introduction that led to the FDA approval of avelumab as switch maintenance therapy. So let me start with a non-muscle invasive disease, and I just want to point out, in the interest of time, I will not show the whole data sets that led to the approval, but in January 2020, the FDA approved pembrolizumab, an anti-PD-1 agent, for BCG unresponsive carcinoma in situ with or without papillary tumors, with or without TA or T1 tumors, in patients who have BCG unresponsive carcinoma in situ and are not eligible for radical cystectomy because they are very frail or they have other medical problems, or they elect not to have radical cystectomy. And the point I want to make here is that patients who have indeed BCG responsive non-muscle invasive bladder cancer, the standard of care remains radical cystectomy and cystoprostatectomy in men with pelvic lymph node dissection. The problem is some patients are too frail, again, too sick to undergo that procedure, and others refuse it despite canceling. So pembrolizumab fills in one of the unmet needs there. And the approval actually came after an ODAC meeting that the FDA had to convene to get, expert opinion because of the, kind of very promising, important data from the phase 2 Keynote-57 trial. But because it was a phase 2 trial, there was no comparator control. There was significant discussion about, whether pembrolizumab met the benchmark. But I think the approval was reasonable and again, represents another option for the patients, in addition to intravesical chemotherapy that we're using sometimes in those scenarios, as well as clinical trials, which is always, an important option. And again, these are for patients who cannot get radical cystectomy or refuse not to have it. There is other plethora of agents, I would say, in this BCG responsive non-muscle invasive disease setting. And I just selected a few of them for the presentation here and for balance of the data. You can see that there is this agent called nadofaragene firadenovec. This actually has phase 3 data. Again, without an active comparator, because we don't have a breakthrough other good option in this setting. So the FDA allows these single arm phase 2 or phase 3 trials, and the data with nadofaragene firadenovec look very promising. And I think the FDA is reviewing this data real time. So we'll see whether this agent that I list first in that list will get approval or not, like pembrolizumab did. There are other agents like the oportuzumab monatox. I don't expect you to remember all these names by heart, but there is also data with this agent, the oportuzumab monatox. This is actually an interesting, it's kind of an antibody drug conjugate, the second item listed in my list here, which has a diphtheria toxin against the bladder cancer cells, and also has data from a large phase trial recently reported, and the regulatory review is ongoing right now, and this data is undergoing review. The other agent of interest is number 5, the ALT803. There is some promising data in early phase trials, and larger phase trials are ongoing. And the atezolizumab actually underwent a very similar trial with Keynote-57, the pembro trial that I showed you in the previous slide. Interestingly, the data were presented at ASCO virtual meeting. The study was almost very near completing accrual, where the intermediary benchmark endpoint was not met. So the trial closed technically in accrual a bit earlier. However, the data look interesting, and they are not very far away from the data with pembrolizumab. However, because of this already set benchmark in that study, I think atezolizumab, it will be very hard for that to get a regulatory approval in this setting. Again, this is BCG responsive, non-muscle invasive disease, and different options are being tested in clinical trials. For now, patients who cannot get radical cystectomy for this setting, they have options of pembrolizumab intravenously or intravesical chemotherapy or clinical trials. So it's always a good option. I'm going to move to muscle invasive disease and talk about neoadjuvant or adjuvant data. And I think it's very interesting to remind ourselves why cisplatin-based combination chemotherapy as a neoadjuvant treatment is a standard of care for muscle invasive resectable bladder cancer. And the main reason we give systemic cisplatin-based chemotherapy is to eradicate micrometastasis. And that's, I think, is the most important reason. That's what I explain to the patients when I talk to them about neoadjuvant chemotherapy. We also want to downstage the tumor and actually improve upon the pathological complete response rate, and higher pathological complete response rate at the time of radical cystectomy corresponds to higher overall survival, longer overall survival. So it's a surrogate endpoint on in a trial level. The question still remains whether in the era of immunotherapy, whether this principle also applies, whether pathological complete response is a surrogate for overall survival. In the neoadjuvant immunotherapy trials, this is going to be investigated in the ongoing studies. The other option would, and the benefit of giving neoadjuvant chemotherapy is you don't need to recover after radical cystectomy to receive systemic therapy. You do it up front. And there is also the opportunity to evaluate the responsiveness of the tumor and the biology of disease in a real-time setting. And this can have potential treatment implications down the road and also prognostic implications. If you have no response to neoadjuvant cisplatin-based chemotherapy, you have significantly high risk of recurrence based on pathologic states. This usually portends poor prognosis, and it's important to take into account for further options. In the neoadjuvant trials, you also have the opportunity to interrogate the biology of disease, and you look at tumor tissue, blood, and urine, as well as now we do some studies using stool to look at the microbiome. So it's a great niche for clinical trial and drug development in the neoadjuvant space. And obviously, cisplatin-based chemotherapy has level 1 evidence. We use either gemcitabine cisplatin, and I use gemcitabine cisplatin on a 21-day cycle. I use 4 cycles for clinical node-negative disease in the neoadjuvant space. The other option is dose-dense MVAC, and this is given every 2 weeks with growth factor support. So either GemCis or dose-dense MVAC with the latter with growth factor are the 2 regimens being given in that setting. If someone cannot tolerate cisplatin, there is no good evidence to substitute carboplatin in this neoadjuvant setting. And that's one of my things I always discuss with my colleagues. If someone is not fit enough for cisplatin for whatever reason, kidney function, performance status, significant hearing loss, major neuropathy, or heart failure, asymptomatic, in those cases, you can go right to cystectomy or clinical trial, it's always the right answer, or in selected patients, you can try bladder preservation approaches. As I mentioned, dose-dense MVAC or GemCis is what I use in the neoadjuvant setting. There is no high level of evidence comparing GemCis with dose-dense MVAC in the neoadjuvant setting. The SWOG 1314 trial compared the 2, but was an indirect comparison. The trial was not powered to compare the 2 regimens. However, the pathological complete response rates appear to be close to each other. I would say similar. If you ask me in clinical practice, if I feel comfortable giving dose-dense MVAC, that's probably my slightly biased favorable option. But I'm very fine with GemCis as well, depending on the level of comfort of the provider and the patient. And either of those 2 regimens are fine as a neoadjuvant therapy for muscle invasive bladder cancer. Of course, we do plenty of immunotherapy clinical trials. The role of immunotherapy in the neoadjuvant or adjuvant setting for muscle invasive disease is still investigational, but plenty of clinical trials, as you see in that slide. You have plenty of phase 2 trial promising data supporting phase 3 trials. And right now we're doing phase 3 trials. And I will actually suggest to all of the colleagues who have patients who are considering neoadjuvant therapy, either cisplatin fit or cisplatin unfit, if the patient has interest, reach out to us. We have trials in every setting, cisplatin fit and cisplatin unfit. And we're actually now just opening on Monday a neoadjuvant trial combining chemo and immunotherapy, dose-dense MVAC and pembrolizumab for variant histologies. So patients with non-urothelial, predominant or pure variant histology. So we try to capture all the space there with urothelial predominant, non-urothelial predominant, and cisplatin fit and unfit patients, and we have trials for all of those patients. What about adjuvant therapy? Do you ever consider it? And the answer is yes. The take-home point is for someone who never received neoadjuvant chemo and has PT3 or PT4 stage and or node-positive disease at cystectomy, I'm offering adjuvant cisplatin-based chemotherapy, either of those two regimens I mentioned before, in order to prolong disease-free survival. The overall survival data is marginal in terms of the meta-analysis that was done, but I think it's very reasonable to consider this adjuvant approach in those who never received neoadjuvant. If you already received neoadjuvant chemotherapy, there is no high level of evidence to give more adjuvantly if you didn't respond well. And those are the patients who go on adjuvant clinical trials. That's a great opportunity. Speaking of adjuvant clinical trials, this is the INVIGO010 trial that was presented by Dr. Maha Hussein, who happened to be one of my main mentors during fellowship about 10 years ago now. And Maha presented the data at ASCO virtual meeting 3 months ago. And the trial was straightforward, adjuvant atezo single agent versus adjuvant observation. Just to point out here that Dr. Bhatia has a different trial in Merkel cell carcinoma with adjuvant avelumab, so just to plug in his trial here. But the point is that there are many attempts to use adjuvant IO versus observation in patients after radical surgery, and that's the approach we used in the INVIGO000 for bladder cancer or upper tract urothelial cancer after radical cystectomy or radical nephro-U. Patients were allowed to have received neoadjuvant chemo, but neoadjuvant chemo was not mandatory. So either population was eligible. Primary disease endpoint was disease-free survival, and secondary endpoint was overall survival in this study. Unfortunately, despite the promise, this trial was negative, did not meet the primary endpoint of DFS, and of course, did not change practice. As you see, the curves are very close to each other. The data was presented at ASCO, but now the manuscript is being submitted for publication. So stay tuned. We're going to present the data in a manuscript, hopefully very, very soon. Overall survival is kind of a moot point because the primary endpoint of DFS was not met. However, you see here again, no significant discernible signal of difference. There is some small trend, but again, I would not call it significant. So technical adjuvant atezo did not appear to work. And to our surprise, last week we got a press release from a different similar trial with adjuvant nivolumab versus placebo. And this trial actually, in contrast, met the primary endpoint of disease-free survival versus placebo. The atezo trial was versus observation. We have not seen the data, so we have to see the data from the CheckMate 274 trial, but it's interesting you have one negative and one positive trial, so it's still the question remains, and hopefully we'll get some more data from the adjuvant pembro trial. It's called Ambassador. We have this trial open and we're accruing very well at the University of Washington and SCCA. And this trial is adjuvant pembro versus observation. Is led by Dr. Apollo at the NCI. It's a cooperative group trial with Alliance, SWOG, Energy, and Ecocacrin supporting it, and we're actively accruing. So you have a patient who received neoadjuvant chemo or did not receive neoadjuvant chemo and you think is a good candidate for this trial, let us know. We're actively accruing. We're also accruing in this interesting adjuvant trial with an FGF receptor inhibitor called infigratinib. This trial is led by my friend, Dr. Pal at City of Hope, and Dr. Nan, who is also in LA in USC, and I'm also in steering committee of the study, and we're looking at infigratinib for patients selected based on the presence of mutations or fusions in the tumor tissue in FGF receptor 3. So if you have a patient without a mutation that it's checked by genomic sequencing, this patient can be a potential candidate for this trial called Proof 302. So let us know, we can definitely evaluate the patient in the adjuvant setting. Again, patients with prior neoadjuvant chemo are allowed, but prior neoadjuvant chemo is not mandatory. So either population is fair game for this trial. Just a couple of words about bladder preservation. This is not for everybody. There are particular criteria we use for bladder preservation, and the ideal candidates include patients with smaller kind of T2, small T3 tumors, away from the trigon of the, where the ureters are, away from the area. Patients without significant hydronephrosis and also patients without extensive carcinoma in situ, because carcinoma in situ, there's some suggestion that might be more resistant to radiotherapy. Also patients with, we want them to have good bladder function and good capacity, and also usually with pure urothelial cancer, at least predominant urothelial cancer, because we do not know how the predominant variant histology behaves in these scenarios, but we allow patients in, with predominant urothelial mixed with other histologies. Usually these patients are allowed, in these scenarios. We have two phase 3 trials in this setting, the SWOG 1806, led by Dr. Singh. I'm also part of this committee, and the primary endpoint is bladder intact disease-free survival. And the question is, after you do maximum optimal TURBT, you do either chemoradiation alone, standard of care, or you do chemoradiation plus atezolizumab to see whether the addition of atezo can actually improve upon the outcomes in these patients. So, in terms of chemotherapy, you have 3 options. In the clinical practice, when you do chemoradiation after maximum TURBT, is either cisplatin alone, weekly, I usually do it on Monday, or the UK regimen from the BC 2001 trial, 5-FU C, or gemcitabine that usually is given twice a week or once a week with different dose. So either of those options can be utilized as a radiosensitizer. And in my practice, I do not use neoadjuvant chemotherapy followed by chemoradiation. I do maximum TURBT, optimal TURBT followed by concurrent chemoradiation. And this trial is checking whether the addition of atezo makes a difference. Very similar trial by Dr. Balar in NYU and colleagues. And this is a chemo radiation plus minus pembro trial after maximum TURBT. Similar trial, some differences, but interesting to see what these trials will look like in the future when the results come back. Moving to metastatic disease, I would say that we have data with single agent checkpoint inhibitors, and we have data with single arm atezo and pembro from phase 2 trials that actually led to the accelerated approval of atezo and pembro in the frontline setting of advanced urothelial cancer. The approval is specifically for patients with PD-L1 high tumors in the frontline setting that are not fit for cisplatin. So cisplatin unfit, but PD-L1 high patients. In US, the FDA allows the use of either of those checkpoint inhibitors in patients who are not fit for any platinum chemotherapy. So if you cannot get even carbo, then you can get atezo or pembro in the frontline setting regardless of PD-L1 expression. My suggestion is that most patients actually are fit for carbo, so I think we have to be careful and select the patients properly. There's a bunch of phase 3 trials that was presented recently. The Danube trial that compared durva-tremi combination to chemotherapy in all comers, intent to treat population, did not meet the primary endpoints, and also the comparison between durvalumab alone with chemotherapy in PD-L1 high patients did not meet the primary endpoint. This was presented at ESMO last weekend by Professor Pauls, and again, Danube trial, very important trial, long follow-up, good design, but did not meet the primary endpoint. Checkmate 901 is still ongoing. It's EP-Nivo versus chemo, and also has a randomization of Gem-Cis-Nivo versus Gem-Cis. And this trial is not reported yet. We're all waiting to see what happens and whether the doublet IO will beat chemo or not. But again, the Danube trial in all comers, ITT population did not meet the primary endpoint. Genito-361 and IMvigor130, I'm going to show you the data right now. These trials have been reported. The Genito-361 did not meet the primary endpoint. I'll show you the data. There are 2 other trials, the Nile trial, chemotherapy alone versus chemo-durva versus chemo-durva-tremi. Interesting to see the quadruplet there, how this data will see in the future. And also we have the EV302, which is enfortumab vedotin, an antibody drug conjugate against Nectin-4, plus pembro compared to chemotherapy. So interesting trials. We have to see in the future how this data will pan out. The last 2 trials, Nile and EV302, are still ongoing. They're still on accrual. IMvigor130, I'll try to keep it simple for you. The main question was chemo-atezo combination concurrently versus chemo placebo, arm A versus arm C. There was also a secondary comparison between atezo alone versus chemotherapy placebo. And the primary endpoint was PFS and OS as co-primary endpoints. Bottom line, there was a modest, statistically significant, but in my opinion, not clinically significant PFS benefit with adding atezo to chemotherapy. But this, as you see, it's a median PFS benefit of 2 months, probably 1 scan away, and the hazard ratio is 0.82, not that impressive, and the overall survival had a trend, but did not meet significance. So the longer follow-up is still pending a year later. We'll see what happens. But based on this data, I'm not using concurrent chemo-IO in advanced urothelial cancer. This is different than data in lung cancer or stomach cancer. We don't know why, but the concurrent chemo-IO combo does not appear to substantially improve outcomes in this disease. The atezo versus chemo alone, it's interesting. There are some differences, between PD-L1 low and PD-L1 high. The bottom line is there is no clear statistically significant difference between, chemo alone and atezo alone, either with PD-L1 low, PD-L1 high. In PD-L1 low, the chemo seems to be doing better in the first year, but then the curves come together, hazard ratio 1.07. PD-L1 high, there is a trend, not significant, favoring atezo, but again, this does not cross statistical significance in the subset analysis. Safety is consistent with what you expect to see with this agent, chemo and atezo, and it's manageable, seems to be the case, but it's not, as I mentioned, substantially improving outcomes, but it's a manageable combination to give. But as I mentioned, we don't do it concurrently in urothelial cancer. The data from KEYNOTE-361 also supports this notion that the combination of chemo-IO does not do that well as concurrent combination. Chemo-pembro versus chemo alone, or pembrolizumab versus chemo, and the primary endpoint PFS was not met. Primary endpoint OS was also not met. And then pembro alone versus chemo in all comers, no significant difference. Toxicity, as I mentioned, expected what we expect with pembro. What you expect with chemo, you add them together, you get more toxicity, but no substantial improvement in benefit. So based on this data, if you plan to start chemotherapy, there is no role of adding IO in addition to chemotherapy concurrently. But the problem we all have is you get a response or stable disease with chemotherapy. And the question is, you cannot maintain this forever because you have toxicity if you give chemotherapy for a long time. So the question is, can you maintain the response to chemotherapy or stable disease? The median PFS with chemo alone is 7 to 8 months, and response rate with GEMS is about 50–55%, with CarboGem is about 35–40%. So the question is, can you maintain this benefit with a Javelin Bladder 100 trial? Was designed to answer this question of whether switch maintenance immunotherapy with avelumab, PD-L1 inhibitor, can maintain the benefit achieved with chemotherapy. This is a trial that Selender mentioned before that was published at the New England Journal of Medicine on September 18, just a couple of weeks ago, and at the same time with ESMO. And I was very honored to be the senior author of this paper, along with a great team, Professor Paus and many others. This is a design of the Javelin trial. This is a patient population who completed a response or stable disease, and they were enrolled in the study. The design is randomized on patients getting avelumab plus best supportive care versus best supportive care alone. The patients were stratified based on the best response to induction chemotherapy and the site of metastasis, visceral or not. The primary endpoint was overall survival in all comers, regardless of PD-L1 expression, and also in the subset of patients with PD-L1 positive tumors. And secondary endpoints were PFS, safety, and so on and so forth, as well as patient-reported outcomes. The primary endpoint was met. There was significant difference with overall survival benefit with switch maintenance avelumab plus best supportive care versus best supportive care alone. And this was a median overall survival difference more than 7 months. And you may agree with me that this is not very easy to get that a big delta in overall survival in solid tumor oncology. And the hazard ratio was 0.69 with a very significant p-value. The previous curve was in all comers, all population. Here is the PD-L1 positive patients, even higher degree of benefit, again, with switch maintenance avelumab, prolonging overall survival. And this benefit appears to be across different subgroups, and there was no significant treatment-based group interaction in the interaction test that we did. So all patients appear to benefit with variable degrees. So my take-home point is, if your patient finishes chemotherapy, has response or stable disease, then you can consider switch maintenance avelumab as level 1 evidence. And the FDA approval came on June 30th of this year, just 1 month after Professor Paul saw the data at ASCO. It was one of the most rapid, actually, FDA approvals I have seen. From the time you present the data, it was only a month until the FDA approval came, and subsequently the guidelines changed. So the ESMO guidelines, CCN guidelines have changed and have level 1 evidence hopefully soon, since the paper now is published of this agent. About 2/3 of the patients in best supportive care arm receive subsequent therapy, which is actually not a low number. It's actually higher than expected because many patients drop off the first line because they progress quickly. So it's actually, in my opinion, one of the strengths of the study, not weaknesses, that 2/3 of the patients had subsequent therapy. Toxicity was as expected with avelumab. There was, I think, a 7% of grade 3 treatment-related adverse events, overall well-tolerated and no new safety signals. Platinum refractory disease, we use pembrolizumab as an agent with level 1 evidence for platinum refractory IO-naive patients based on the KEYNOTE-45 trial. The response rates are kind of modest with single agent checkpoint inhibitor, and we're doing clinical trials with combinations right now to see whether or not the combination IO therapy combined with other mechanisms of actions or other immunotherapy agents can improve these outcomes. But in the platinum refractory setting, pembrolizumab has level 1 evidence. I want to draw your attention very quickly to the sacituzumab govitecan data from ASCO. This is an antibody drug conjugate against TROP2, and the data is very promising. This anti-TROP2 antibody drug conjugate is being tested in the TROPHY-U01 trial. We have this trial open at our cancer center, and I will show you data from cohort 1, single agent sacituzumab. There is also impressive data that was shown at ASCO with cohort 2, which is in platinum not fit patients, but cohort 2 is still ongoing. The cohort 3 is interesting, is pembrolizumab plus this antibody drug conjugate, sacituzumab govitecan, and we don't have data yet, but it's interesting to see what happens with a combo. Single agent sacituzumab govitecan has an overall response rate 27% in heavily pretreated population. We have multiple prior therapies, and single agent taxane has a response rate of about 10, maybe 14%. So this one is almost double of what we see with historical data of chemo, and 3/4 of the patients had tumor reduction, very promising data. Toxicity needs some attention with bone marrow suppression and diarrhea being the most common adverse events. Usually these are manageable side effects, and the growth factor support or dose reduction can help with management of neutropenia. Is only 10% grade febrile neutropenia, and is usually again manageable with dose reductions or growth factor. The diarrhea is usually situational around the dose of the drug, the administration date, and is usually well managed with education of the patient, hydration, and anti-diarrhea medication. So keep an eye for the sacituzumab govitecan, and we still have the trial open. The cohort 2 and cohort 3 are still accruing. And we have a phase 3 trial that is coming up called TROPiCS-4, sacituzumab govitecan versus chemotherapy in this heavily pretreated population of patients after multiple prior lines of therapy. So there's no limit in the prior lines of therapy. This is my view of how urothelial cancer today. This is again my opinion. People may agree or disagree. Cisplatin fit patients, GEM-CIS followed by switch maintenance avelumab based on the Javelin Bladder 100 trial that was just published, as Selender mentioned, at the New England Journal of Medicine. Metastatic patients who are not fit for cisplatin, CarboGem is a usual option for those patients. Those who are PD-L1 high tumors or they are not fit for any chemotherapy, they may get pembro or atezo. In my practice, this is a small proportion, maybe 5 or 10% of patients are not fit for carbo, and I use pembro or atezo on those patients. The question between CarboGem followed by avelumab versus pembro, we don't have straight comparison between those approaches. But the data again from Javelin trials showed the longest overall survival we have seen in this disease. Again, we have no comparison directly between CarboGem followed by avelumab versus pembrolizumab. That may be a trial design in the future. Pembrolizumab has level 1 evidence in the second line setting after platinum refractory disease, and there's data with erdafitinib, an FGFR receptor inhibitor, in patients with genomic activating mutations or fusions, not amplifications, in tumor tissue for those patients. So erdafitinib is an option based on single-arm phase 2 study and has not been compared yet with pembro, but there is a phase 3 trial comparing pembro with erdafitinib called Thor trial. We don't have data yet. In third-line space, and enfortumab vedotin, antibody drug conjugate against Nectin-4, has accelerated approval based on single-arm phase 2 study called EV201, and there was a press release showing that in the phase 3 trial, EV301, there was a hazard ratio 0.70 favoring enfortumab vedotin versus salvage taxane single agent chemotherapy or Viflin chemotherapy. We have not seen the data from EV301 but enfortumab or erdafitinib are options in this third line space for patients based on medical comorbidities, toxicity profiles. The optimal sequence has to be yet defined in these patients, but that's probably a summary of how I would approach this disease. But my favorite thing is clinical trials. So in every single setting, we have many of those. So keep us posted if there are patients with metastatic disease or early stage disease. We're happy to evaluate for clinical trial eligibility. So take home message very quickly before we move to some brief prostate cancer updates. Pembrolizumab got FDA approval for BCR responsive CIS for patients who refuse radical cystectomy or do not go for radical cystectomy. For cisplatin-fit patients, I use cisplatin-based chemotherapy or clinical trials. In the adjuvant setting, Atezo negative trial, Nivo positive trial. We have to see what happens with the adjuvant Pembro trial and to see the data from the adjuvant nivolumab study. In first line setting, there's phase 2 single arm data with Atezo and Pembro. The phase 3 trials do not support any benefit of checkpoint inhibitor alone versus chemo. We have definitely level 1 evidence now with switch maintenance avelumab after response of stable disease to induction chemotherapy in the frontline setting, and that's a new standard of care for those patients who start with chemotherapy. And platinum refractory disease, Pembro, or as I mentioned, erdafitinib can be given, and enfortumab is an option, probably in the third line space. Moving to prostate cancer briefly, just to show some updates from ASCO and from ESMO. I will go very quickly through the material here. I realize I have way too many slides. The first study, it was a phase 2 trial, showed at ASCO, just for awareness, the lutetium PSMA, very promising phase 2 trial data, not practice changing, but you see some significant PSMA responses with lutetium PSMA, these theranostics, right, or radiopharmaceuticals. And there's some toxicity, hematological toxicity, GI toxicity, taste changes, neuropathy, but overall, there is significant interest with lutetium PSMA radiopharmaceutical in this disease. The phase 2 trial was not practice changing, but would definitely raise the awareness and raise interest for the phase 3 trial, comparing lutetium with standard of care therapy in metastatic castration-resistant prostate cancer. So we look forward to the phase 3 data, but keep an eye this treatment, lutetium PSMA, in the Vision trial, the phase 3 trial coming up. There is a lot of utilization of PET-CT, novel imaging, in prostate cancer, and we have a registry here, as well as a clinical trial led by Dr. Yu at UW-SCCA. And this trial I'm showing you here is called Condor. This is led by Mike Morris and colleagues. They try to see whether this novel fluoride DC-FPYL PET-CT can help detect metastatic disease in patients with biochemical recurrence, rising PSA. And actually, this was a positive trial suggesting that among different readers, you can detect actually disease in this biochemical recurrence setting, and this far exceeded the benchmark of detectability with this scan in the biochemical recurrence setting. So this is definitely not practice changing, but suggests that this new modern imaging with these PET scans can detect earlier, more sensitive detection of recurrent prostate cancer. When you have negative conventional scan, CT or bone scan, these agents can detect disease. And these actually can enrich patients for clinical trials. And we have those trials open right now at our center. Of course, future studies, these clinical trials will evaluate whether it's clinically useful to utilize this novel PET imaging and whether it makes a difference to detect disease earlier versus later. So this is a lot of attention here, and I think our trials hopefully will shed more light, but despite not being practice changing, it definitely supports the ongoing trials utilizing this novel PET imaging in those patients to answer the question, does early detection matter? Does early detection lead to better outcomes or not? The last study on for ASCO was this phase 3 trial looking at the new LHRH antagonist called relugolix. This is actually an orally available agent compared to Lupron, and this agent has the advantage of being orally available, so you don't need to inject the patients, but also has a rapid reduction of testosterone. The study actually, as you see, led to significant reduction of testosterone, as you see, and also in terms of the response rates. The relugolix, this GnRH antagonist, was actually not inferior to leuprolide, you can actually see higher response rates. Now you can argue, is there any clinical useful space to use this agent? I think it's very limited. There is potential that these LHRH antagonists have fewer cardiovascular events compared to LHRH agonists like leuprolide. So that may be a population of patients with high cardiovascular risk, prior MIs, or coronary artery disease, that you may opt for this agent. However, I think that most of the patients we have in the clinic, they start maybe bicalutamide for a few days concurrently with leuprolide, and this testosterone blockade may avoid the flare, the surge of testosterone. So I see a role for very few limited patients with regulolics, patients with significant cardiovascular disease who have no absorption issues. That could be a population of patients, but there are issues for potential compliance as well as cost, because these agents, as you know, can be expensive. And again, we have to see how it fits with our treatment paradigm. Most patients still get LHRH agonists concurrent with testosterone receptor blockade, at least in the beginning. And then we escalate therapy, adding a novel anti-androgen or docetaxel in some patients in the metastatic hormone-sensitive prostate cancer setting. I will go just very quickly in the next couple of minutes, if you allow me, to show some very interesting data from ESMO from 2 weekends ago. This is, one is not practice changing, the second is practice changing. So the not practice changing is the e-potential trial. This is abiraterone, that is androgen synthesis inhibitor, has approval in metastatic hormone sensitive disease and also metastatic castration resistant disease. And in the second indication of the metastatic castration resistant disease, the question is, if you add ipatasertib, which is a targeted therapy inhibiting the PI3K AKT-mTOR pathway, do you improve outcomes, PFS and overall survival, versus abiraterone with placebo? And this study showed that in patients who have P10 loss by IHC, there is a statistically significant improvement in radiologic progression-free survival. That may statistical significance, but in my opinion, the difference is small. It's only a couple of months, maybe one scan away. Again, it doesn't raise enough to the bar to change practice, especially in the intent to treat population. There was no significant difference in radiographic PFS, and it's interestingly, if you define this pathway genomically and you select patients genomically, there seems to be a trend towards benefit in radiologic PFS. This was a secondary endpoint, though. The primary endpoint was based on immunohistochemistry. So definitely interesting promise for the future, but overall survival was not met. So I would not change practice at this point based on modest PFS benefit, based on no OS benefit, and based on toxicity. As you see, skin rash, diarrhea, hyperglycemia, transaminase elevation, all this can be, much more with the addition of the targeted therapy, and there was significant discontinuation rate. So in the context of toxicity and cost, I would not change practice. I will not add this agent, but we have to see what the longer term overall survival data looks like. So far, there is no overall survival benefit. Moving now to the PROfound trial that was practice changing. This data was presented by Dr. Hussein at the prior ESMO meeting. And now we have the updated data by Dr. Matteo. This is PARP inhibitor olaparib. Just to remind you for context, there are two PARP inhibitors approved in metastatic castration-resistant prostate cancer, olaparib and rucaparib. They are different in the indications. Olaparib is based on a phase 3 trial, PROfound, and rucaparib is based on the Triton phase 2 trial. And rucaparib is approved only for BRCA1 and 2 mutations. Olaparib has a broader approval based on this trial, and I will show you the data right now. The cohort A was patients with BRCA1 and 2 and ATM mutations. Cohort 2 was all the other alterations. Primary endpoint was radiologic PFS, and overall survival was also looked at. And actually, olaparib in this particular trial improved overall survival. This is practice changing. In patients in cohort A, there was significant difference. Hazard ratio 0.69, and these are BRCA1, BRCA2, and ATM mutations. And again, this is genomically defined. And it's interesting, even with a crossover, there's still some benefit there with olaparib. The control arm may have been suboptimal because these patients already progressed on abiraterone, they got enzalutamide and vice versa. And some people may argue this was not the right control. We may use single agent taxane in those patients, but still, despite this caveat of a suboptimal control arm, this is, a positive trial. Cohort B remains a question. I'm not convinced personally that there is significant benefit in all the other gene alterations, all the other genes in cohort B. The data do not support that so far, but because there are very small groups and it's hard to find the benefit, the FDA actually approved the whole package with all the 15 genes. It's a lot of discussion about that in the literature and in social media. But as I mentioned, even if the benefit appears to be driven mainly by BRCA1 and BRCA2, the approval is broader, and the question remains, do you use this agent in patients with other gene mutations? Toxicity can be an issue with PARP inhibitors. Anemia, nausea, fatigue, anorexia, vomiting, diarrhea, constipation can happen. I would leave you with this, and thank you so much for the honoring invitation. I covered a lot of data, but I'm here to take questions. Thank you for your time.
Thank you, Petros. That was outstanding. So we will, Petros, if you are not in a hurry, we will have the other talk and then have a panel discussion at the end of it. Thank you.